The Integritas Institute for Ethics is an educational department at the St. John Paul II Newman Center here at the University of Illinois at Chicago. My name is Chris Saliga. I'm both a registered nurse and a Catholic priest of the Dominican Order, and I'm blessed to be in current service as the interim director of this institute. Here at Integritas, we strive to bring helpful wisdom to the table on a variety of ethical issues. Sometimes our presentations are explicitly Catholic, as is the case today, and explicitly theological, as is the case today. Sometimes they're presentations that are simply consistent with Catholic social and moral thought. Now, we do all this in grateful collaboration with various student organizations, faculty, staff, and administrators here at UIC. Ryan Holliday is in his second year of the DPT program here at UIC's College of Applied Sciences. He's an alumnus of Purdue University, class of 2016. Now, both while at Purdue and UIC, Ryan has significantly contributed to a variety of ministerial successes in close collaboration with any number of Dominican friars. Given the fact that today's distinguished speaker happens to be a Dominican friar and a former lead superior of our Midwest region, Ryan Holliday is particularly well poised to introduce him. And so I present to you Ryan Holliday.
Charles Bouchard earned his doctorate in sacred theology at the Catholic University of America in 1987. He currently serves as Senior Director of Theology and Ethics at the Catholic Health Association of the United States. As such, he writes on issues such as healthcare, bioethics, Catholic identity in sponsored institutions, and the intersection of political life, religion, and faith. His most recent books include Whatever Happened to Sin, Virtue, Friendship, and Happiness in the Moral Life, Sexuality and Morality, Answers for Modern Catholics, and he edited a volume of essays entitled Incarnate Grace, Perspectives on the Ministry of Catholic Healthcare. Prior to joining the CHA, Father Bouchard served as President and Associate Professor of Moral Theology at Aquinas Institute of Theology in St. Louis for 18 years, at which he helped develop the Master of Arts in Healthcare mission program. I am honored to present to you Father Charles Bouchard.
Thanks, Ryan, for the invitation. I want to mention that, like Chris, I am a Dominican friar, which is what that little OP after my name stands for. It really is Order of Preachers, but St. Dominic founded us, so we're often called Dominicans. The STD after there doesn't mean what healthcare people usually think it does. It actually stands for Doctorate in Sacred Theology, and that developed a long time before the other one came around. Anyway, just to clarify that. I want to talk today about, as the title suggests here, about an issue that crosses political, clinical, ethical lines, and you know it's in the news every day. I mean, it was really at the foundation of the debate about the Affordable Care Act. That discussion is by no means completed yet. And I want to say a little bit about, first of all, about what many people perceive as the problem with rights language when it's applied to anything, but especially healthcare, and then how the Catholic tradition looks at this. We've got a perspective on it which is a little complex, but I think it'll make some sense to you. So the first question we might ask is, what do we mean when we say a right? Somebody has a right to something. And the kind of classic definition of a right is to say that it's a moral power. In other words, if I assert that I have a right, that gives me somehow, and that's where the complexity comes in, it gives me the opportunity or the ability to obligate someone else to do something or to not do something. So a moral power, now it's nice simple language, but of course it's pretty complex when it plays out. And we could talk about rights as negative or as positive. In other words, I could have a negative right to be to not have something done to me, a right of non-interference, as opposed to a positive right, which is one that obliges or enables me to lay claim to something. So it could be a right to health care, it could be a right to travel somewhere, a right to have a visa, a right to citizenship, which is, of course, another issue about rights today that we're dealing with. So it works both ways. And one of the key points that I'm going to make today is that there are a lot of Americans, I think generally culturally, we're much more in favor of negative rights and non-interference rights than we are entitlement rights. We, as a culture, feel much more comfortable with the first kind than with the second kind. If we analyze this rights language, it's real important to understand that any right, in order for it to be coherent, has three parts. And there are different languages, different kinds of language that are used to describe this. But first of all, there has to be the subject of a right. In other words, who's making the claim? If I say I have a right to bear arms, okay, I'm the person that is making that claim. The second thing is that there has to be an object of the right. In other words, what am I claiming? What am I seeking? Or what am I saying that I have a right to? And that, as I suggested, could be something negative or positive. I could claim that I have a right to health care, or I could claim that I have a right to free speech. In other words, not to be bothered or interfered with as I exercise this right of free speech. And then the third thing is the term of the right. And that means if I have a right to something, in order for it to mean anything, somebody else has to have a corresponding obligation. Otherwise, it's meaningless. I can say, well, I have a right to a new car every year. Okay, great, have at it. Who's gonna provide that for you? And this is where the discussion often breaks down, because sometimes there are what are called manifesto rights, in which people say there is a right to free speech, there is a right to protest, there things that are kind of seen as general human rights, but it's not always clear who is obligated to provide that or to respect it. And that's exactly where the problem arises in the right to health care. Much of the debate centers on, okay, you say you've got a right to health care, a right for me to pay for your appendectomy or your transplant. Who's going to pay for that? That's really where a lot of the problem is about this. If we review literature, and there's a whole lot of it out there, and ask what are the most common objections to using rights language about healthcare, there's probably about 5 or 6 in general. I'm going to sort of summarize them here, and you may be aware of others. But when you look through the reasons that people object to this, these, I think, are the main ones. The first one, which usually is the first one that's invoked, and especially with regard to health care rights, is that the right to health care is unconstitutional. That it's not in the Constitution anywhere that we are guaranteed or entitled to any amount of health care. And one example of this would be this quote. I apologize that I left the author's name off here. But he says, in the American view, the only rights are the rights to life, liberty, and the pursuit of happiness. And they'll often emphasize the pursuit. In other words, you don't have a right to happiness, you've got a right to pursue it, but I don't have to do anything to make that possible for you. And he says in here, and this is a very good statement of what I mentioned earlier about American culture's preference for non-interference rights, is that the American idea of rights imposes no obligation on other people, but merely the negative obligation to leave me alone, or to leave you alone. Americans are very comfortable with that. When it gets into talking about, okay, I have a right for you to do something for me, that becomes another question, much more difficult to answer. But leave me alone kind of rights feel good to most people. And I think it's partly a function of just geographically, we have a whole lot of space in this country. And I think the way that this country developed and just kept spreading and spreading, and we've still got vast areas of unoccupied land in the western part of the United States. I think, unlike other places, if you think about the Rohingya refugees in Bangladesh, 800,000 of them, squashed into these little camps. Well, that's got to alter the way that you think about rights and relationships to other people. If you got a whole lot of land and a lot of places to go, you can indulge the idea that really, you want to be left alone. It's just sort of a cultural factor, I think, for us. Another thing is that rights are not free. This gets expressed a lot of different ways, but there's always the question of entitlement rights, as I suggested, about who's going to pay for it. And this author, who actually his name escapes me, but I'll find it here in a moment. He's a primary interpreter of Ayn Rand, who's kind of a libertarian philosopher. He said these rights, or entitlement rights, the founding fathers never dreamed of, because they are rights which require no earning, no effort, no action on the part of the recipient once and for all. So I think, again, here in a kind of characteristic American way, we've sort of transformed rights language into kind of consumer language. In other words, you have a right to this if you have earned it or if you can pay for it. And that's very much part of the reality that we see in the healthcare debate today. And there's, as I'll point out in a moment, there is a valid question here. Especially if we look at rights as a mixture of responsibilities and rights, obligations and corresponding rights. Then the question about how much do I have to contribute obviously is important. The other one would take this a little bit further. A right to health care is simply too expensive, that we cannot afford this. We frequently hear politicians or policymakers talk about the fact, Illinois is a good example where we really are not in a position here to afford much of anything at the moment. We're kind of in bad shape financially. But the problem they always raise is, where does this right to health care stop? Okay, you've got a right to dental care, you've got a right to a new set of teeth, you've got a right to heart transplant, you got a right to new hair. Can I, how about y'all guys? That was something that had some appeal for me, If we've got rights to all those things, where is this going to end? And it's true. They have a point here that there are only finite resources, that we have a lot of different demands on our national, to say nothing of our global resources, and how do we decide where to allocate those? How much goes to defense? How much goes to education? How much goes to health care? And then as you break that down, how much goes to behavioral health? How much goes to physical therapy? How much goes to high-tech interventions? So we've got this constant descending discernment about where we're going to put these resources, which do have a beginning and an end. We don't have unlimited resources. So we're always going to have to think about, where do we dedicate these resources? And another area where it comes out, of course, is the debate between preventative care and things like end-of-life care. You probably know statistics about the percentage of our health care dollars that we spend on end-of-life on the last 3 months even, and yet prenatal care in many states is underfunded. How do we look at that in terms of justice? And working for the Catholic Health Association, which is the member organization for all the Catholic hospitals in the country, we've got about 700 hospitals and about 2,500 other care sites, not including even long-term care. We see different situations all over the country. We've got everything from inner city hospitals to very ritzy suburban hospitals. And so there's this question of inequity of access right to start with. You know, I think you probably all learned a little bit about that, to say nothing of outcomes. And then we're dealing with social determinants of health. You know, people who live in poor or unhealthy neighborhoods are at a disadvantage right from the get-go. You know, and so we got massive problems here in addition to just the money involved. This really translates into, you know, people are going to get free stuff. And people who have to pay for insurance or who get it through their employers are rightfully upset about that. There was an article just a few weeks ago, or actually I think it was a few months ago, entitled, "Is Healthcare a Right?" by Atul Gawande. I don't know if any of you have heard of him. He wrote a book called Being Mortal. He's a physician himself, but it talks about the dilemmas we face at end of life. But in this article, he went back, it was in the New Yorker, he went back to his hometown in southern Ohio and interviewed people about how they understood this idea of a right to health care. And he talked to, you know, some people who were working, you know, they had jobs, they had health insurance, even though maybe it was, you know, not very good, high deductible, that kind of thing. And one of his friends said that she just resented the fact that she had to contribute to health care insurance while her neighbor, she said, who is healthier than I am, gets everything free because she's on Medicaid. And so a lot of people perceive things like Medicaid or other things as people unjustly or undeservedly getting free stuff. This article gave me an insight into people's anger about the lack of equity in the way we allocate healthcare resources. And it was interesting that one of the people that he talked to made a clear distinction between Medicaid, which, as you know, is for the poor and some other classes of folks, and it pretty much covers everything. Now, doctors and care providers don't get reimbursed real well, but nevertheless, you've got comprehensive insurance. They distinguish between that, which they didn't like, and Medicare. And here's what she said about Medicare. "We all pay for that," she pointed out, "and we all benefit." That made all the difference in the world to her. From the moment we earn an income, we all contribute to Medicare, and in return, when we reach 65, we can all count on it regardless of circumstances. There is genuine reciprocity. You don't know whether you'll need health care more health care than you pay for or less. This woman's husband thus far has needed much less. Others have needed more. But we all get the same deal, she said, and that's what made it okay. So there's a deep awareness here about the sense of equity. People generally are okay with Medicare because everybody pays into it. But when it comes to Medicaid or other entitlement programs that people appear not to deserve or not to have earned, then they back away from it, which is exactly, the arguments that we've mentioned here. Another frequent argument about healthcare, being a right is fear of rationing, and this comes up repeatedly. We do ration healthcare in this country. We don't do it the way other places do it, but we do make decisions about who's going to get it and who's not. But people are afraid that universal access is going to strain our resources and lead to rationing healthcare resources, and usually they cite the United Kingdom's National Health Service first as an example of that, an undesirable example, and secondly Canada, which has a quasi-socialized healthcare system, a lot of private ownership, and it's not like not like Great Britain. But rationing is a huge concern, and what exactly rationing means is something that we have not been able to come to agreement about. I mean, does rationing mean you get it if you can pay for it? Does rationing mean we have it, but we're not going to give it to you for one reason or another? Does rationing mean that we don't think that you're worthy? You're not a productive member of society, so we're going to give this heart or this medication to someone else who's more deserving. There are a whole number of ways of defining rationing, but usually when it's used, the term, it it could mean any one of those things. We don't have a clear idea about what it means, at least in terms of a consensus. And so if we are talking about limited resources, then some judgments are going to have to be made about who gets what. I mean, there's no way around that, unless we leave it purely to market forces, which some people would like to do. They see that as the way to deal with this. Others are concerned that there will be a shortage of doctors if everybody gets access to health care, or that doctors will become, and this actually was the language in the article, slaves of the government, that they will be forced to provide health care for people who don't have the means to pay for it. They will no longer be able to practice health care the way they want. And I had a discussion with a physician who is actually a pediatric ophthalmologic surgeon from Canada, highly specialized, who moved to the United States because he told me at dinner that Canada didn't let him practice medicine as he wanted to. He said, "I will treat any patient who can't afford it free of charge." Now, the chances of any patient getting to him in the first place because of referrals is pretty limited. I thought he was being a little disingenuous, and I think he was moving to the U.S. because he could make a lot more money here. That was the bottom line. But there is the issue here, too, in a right to health care, that we are imposing an obligation on health care providers in a different way than if you just see patients who have insurance or who can pay for it or whatever, because you, as healthcare providers, have the expertise which I need. Under what circumstances are you obligated to meet this right to health care that I have? Now, I didn't, these things that I mentioned here, I don't set these up just to be straw men and to suggest that they're ridiculous arguments, although I disagree with most of them at some level. But there is validity to many of them. For example, the claim that it will be too expensive, it is expensive. Providing universal access to health care is going to cost a lot of money. But as you can see from this chart, I don't know how well you can see it, on the far right is the U.S. Per capita expenditure for health care in this country. Now these statistics are about 5 or 6 years old, I think, but they wouldn't be any different today. And as you can see, I think now we're actually paying, this is about $8,000 a year per person. It's closer to $11,000 per person now. If you look at Japan, France, Germany, Canada, and Switzerland, some of them spend half as much per capita as we do. And not only that, but they have better outcomes. They have lower infant mortality. They have some of these countries have higher life expectancy. So somewhere or other, we're not getting our money's worth here. Because in addition to the poor outcomes, we also have much more limited access. We have much more unmanaged chronic illness, and especially in low-income neighborhoods, hypertension and heart disease, diabetes are rampant. Those are very difficult to manage out of an emergency room. But yet, that's where a lot of people end up. So it isn't that we're not spending enough money. We're spending plenty of money on health care. It's just not that we're not getting enough bang for our buck. We're spending money in the wrong way. We could argue about, what that means. You may have questions about it. But we are spending plenty. It's just that it's not being allocated or distributed in efficient and effective ways. With universal care, if we had it, or a right, where we had some kind of a system that everybody had access, probably there would be some kind of rationing, waiting lists, which people always cite as a problem in Canada. But come on, let's face it. How many people, well, probably not many of you have had knee replacements, but nobody has a knee replacement the first day they think they need one. They wait as long as they possibly can. There are other more serious therapies that there are waiting lists for. But again, for reasons I'll explain in a moment, it seems to me that from the Catholic perspective at least, that's a reasonable sacrifice for us to make. There will also be a shortage, I think, of primary care physicians. This has happened in states like Massachusetts, which have a relatively universal coverage. One of the first problems they ran into was access to primary care. That's going to be a problem. We know that. A lot of physicians prepare for specializations because, they're going to have a life. But I think that's being changed because many more physicians are employed, which gives them some more regular hours now. There are hospitalists who deal with a lot of, the inpatient care. So there are changes that will mitigate that. But the critics are right that there are serious inequities in cost, in benefits, in access, in outcomes, and yes, some people pay more and get less than others. No doubt about it. So I don't want to dismiss these arguments. We have to take them seriously because they're persuasive to a lot of folks. So how does the Catholic tradition look at this then? If we were to talk about health care as a right, we would accept that basic notion of a moral power. And our understanding of this really has evolved out of the development of Catholic social teaching, which is really social morality. It's like personal morality, except it's not. It deals with problems that are kind of out there that affect all of us. And even though we've always had notions of social justice, the development of Catholic social teaching really took off in the late 19th century after the Industrial Revolution with problems like, child labor, the lack of clout that labor had over capital. Karl Marx was dealing with the same issues. So we have a whole body of teaching that talks about these ideas like justice, the common good, human rights, which have unfolded over the last 150 years. There were lots of people involved in these discussions. There were Jewish scholars, there were Christian scholars who were not Catholic. Leo XIII really wrote one of the first encyclicals or official church documents on the social question, as they called it at that time. And what they meant was it wasn't personal morality question, it was the social question about what happens when to all these big things that affect everybody. More locally, Mother Jones, if you live in southern Illinois or if you drive down there, you'll notice the monument to Mother Jones on Highway 55 there. She was a pretty feisty labor organizer and worked with the coal miners. And I just put them up here together. They're rather unlikely bedfellows. Somebody once, an industrialist, called Mother Jones the most dangerous woman in America because she was fomenting organizing these workers, which obviously the coal mine companies didn't like. But they were roughly contemporaries. So here is Leo XIII in Rome writing at his desk. Here is Mother Jones in southern Illinois, banging the drum for labor rights. And they were working at exactly the same problems. We don't perhaps have some of the issues they're dealing with today, but maybe healthcare, the right to healthcare is, well, not maybe, it is one of our new social justice issues. If we look at the Catholic tradition, it seems to me that there are three fundamental things which help us answer this question about whether healthcare is a right or not. I call them first order principles of Catholic social teaching, which are human dignity, the common good, and then the way that we understand justice. So if somebody says to me, well, does the church think that that healthcare is a right? I'd have to say, well, yes, but the question's kind of complex because you can't really answer it without looking at these three things. So let me just take a few moments to talk about each one of those. The first one, human dignity, is really something kind of like mom and apple pie. I mean, nobody can really not be in favor of human dignity, in principle at least, right? But precisely because it is so fundamental, it's often taken for granted, and it is often also reduced to an abstraction. We can talk about the ultimate God-given dignity of every human person, And then you look at those refugee camps in Bangladesh and you say, wow, this doesn't really look like a very dignified situation for these people to be living in. So when we talk about human dignity, we've got to make sure that it doesn't collapse into an abstraction, that it is a real tangible thing that we can feel and taste and experience. In other words, human dignity, which God has given us, but which is also a secular value, the right that I have not to be assaulted or offended or abused or tortured. You can argue that without theology as well. It also means that the human person has to be sustained in a certain way. That human dignity means not only that I am a person endowed with that by God, but that I have an adequate share of creation's goods in order to live some kind of a dignified life. This is where we keep coming back. And in the past, it wasn't an issue because there wasn't much health care to go around. Hospitals are a relatively recent invention. We even 100 years ago, 50 years ago, if you think about what health care we had to offer, we are quantum leaps ahead of even 50 years ago. So we've got a lot of ways today that we can enhance human dignity very concretely through health care. And that's a principle for us, that we see in our tradition health care being part of the way that we contribute to and sustain human dignity, without just saying, as the Epistle of James did, go, keep warm and well fed, and then you walk off. Well, nice wishes, but it isn't really going to help somebody experience their own human dignity. Human dignity can be defined in a lot of different ways. It can be non-instrumentality, which means that you can't use a person merely as a means to an end, which clearly happens sometimes. People get ground up in totalitarian systems, especially the human person as an individual is disposable. A person's innate value that is not diminished by age, race, social, or economic status. Clearly, implications here for the elderly. Those of you who are in PT, you're going to be dealing with people like me who are getting older by the minute. We're going to need physical therapy and rehabilitation. A lot of those patients are going to be elderly. They won't all be young sports guys, or girls. It can mean a defining boundary that cannot be violated by others. Just the right to be, laws that prevent battery, prevent people from attacking me, either physically or verbally even. That I have kind of a boundary around me and I deserve protection from other people's assaults. And in many ways, human dignity is kind of the great equalizer. I often tell people that I lived here in Chicago for a while and I used to take the L a lot. And those of you who ride the L know that it too is an equalizer. There are people from everything from investment bankers to single mothers to homeless people. We're all there in the same car. And that really says something about what we're trying to describe as human dignity, that we're together in this. Like it or not, we're in the same fundamental category. That's another way that we would talk about it. I think for us also, human dignity has an essentially relational aspect to it. People cannot flourish outside of human relationships and friendships. And this is, again, a big issue for the elderly who often have little or no family left, for what we call unfriended patients, people often homeless who come to us who really have nobody left, or they don't know where those families are. So there is this relational aspect which we have to consider in healthcare as well. We can't necessarily fix it, but being happy humanly means having friends, and to some extent. The common good is a second principle here, which is kind of to the group, whether it's a small group like a family or a big group like a nation or a community or even the globe. It's kind of to the group what human dignity is to the person. And the way that I sometimes define the common good is to say that it is those things which we all need together, but which none of us can achieve on our own. And again, a primary example of that is healthcare. When I get sick, I can't take care of myself. I got to go to a doctor or a clinic because I need help. All of us do. Public safety is another aspect of that. Education. There are a few people who I guess are autodidacts who teach themselves everything, but most of us need a little help getting where we want to go in life. So there are certain basic conditions or circumstances we call the common good, and this is a definition here from the Catechism of the Catholic Church, a set of conditions which allow us to achieve human fulfillment or happiness. The basic fundamental things that each one of us needs. The common good is not just the sum total of all our individual goods. If we were to write down on a paper here the 3 things we all really want and make a great big list, that's not the common good. The common good is even bigger than that. It is these social conditions to which we all contribute and from which we all expect to benefit. The common good, as some of these other terms, is really a countercultural idea in the United States. I read an article, a newspaper column a while back entitled, "2 Words a Politician Will Never Say." Guess what they were? Common good. And it's true, if you listen to politicians, they rarely ever use that term. Even though, classically at least, the purpose of political life is the common good. That's why we have politics. It's try to work this, I know it's not obvious a lot of the time, but the purpose of political life is for us to come together and to work out this set of conditions which allow people, either as groups or individuals, to reach their fulfillment. It's not just about the group where individuals are dispensable. It should also flow back on individuals. And it's constantly evolving. The common good is tricky because it's this constant renegotiation of circumstances and people's lives. Americans tend to be suspicious of this word because it sounds a little like communism. And when I've given this lecture to senior health executives, which I do a lot, I know many times they were thinking, this is basically warmed over socialism. They didn't always say it, but sometimes they did. I remember once a board member at a Catholic hospital saying to me, "Father," he says, "this is all great, but this is just socialism, right?" And I said, well, if you look at the Acts of the Apostles, it was not exactly free market economy. Now that doesn't mean that we're going to move toward a socialistic system here, but it does mean that we need to find a way to live together where there is a relatively equitable distribution of the resources that we have. And that's what, our political life is supposed to be doing. Well, here's just a statement from Daniel Callahan about the common good in the U.S., and he's pretty blunt about it. And I think he's right on target there. That we don't want to talk about this because it immediately means, and then there's another problem about the government's relationship to the common good, which I'll come back to. That's another problem we face. And as I mentioned, it's difficult because it's a moving target, so the pluralism of our landscape in the U.S. especially makes it hard for us to come to agreement about what this common good might look like. Are any of you from Canada? Any of you Canadian? If you just cross the border and go into Canada, at least when I'm there, I immediately feel a different ethos. I wouldn't call Canada socialistic, but it's a very different way of thinking about how we allocate goods and how people relate to each other. Just crossing the river in Detroit, and you're in a different society. Western Europe generally looks at the way that they allocate goods in a very different way that than the U.S. does. Are there problems with it? Yeah, definitely, but different vision than we have here. These are just some things that I sometimes use to distinguish socialism or collectivism from what we understand in the Catholic tradition as the common good. And you can see some differences here, which I think most of which you'd recognize. And socialistic governments often require ownership of production by the state. Individuals can be sacrificed for the whole. Tries to minimize participation, especially political participation. Authority is often concentrated at the top. If we look what just happened in China, with the president kind of extending his term of office there. Whereas our understanding of the common good differs dramatically from that in a lot of ways, as you can see here. Okay, justice is another element of this, one of the key things: human dignity, the common good, and justice. And basically, the fundamental definition of justice is that each receive his or her due. Now, this is elegant in its simplicity, but it is also not very helpful. Because you could say, all right, well, okay, what does that mean? And for us, justice, again, philosophers spend a lot of time debating this. I think several things that are important. One of which is that justice can be a state of things, that we can have a just society or a just economic policy, but justice is also a virtue. It's a personal quality that some people can exhibit and live out in their lives. And I think the virtue part of it is really important for professionals. You are often going to be faced with making decisions about treating just this patient, perhaps, but this patient, and you've got another patient over there and another patient here, and one who can pay and one who can't. You'll probably often be employed, but still, this virtue of being able to understand how things ought to be allocated fairly. We also see, I think, justice as being a complex reality that involves a network of relationships. It's kind of like the common good. There's one kind of justice which we would call the bottom one here, contract justice. If you go lease a car, you make an agreement with the auto dealership for the use of that car for so many years, and you pay them so much money. It's a deal between you and the dealer, right? It's all spelled out, page after page of fine print. That's one kind. Americans like this kind of justice, contract judgment, in individual agreements, and many of them, especially people who are really in favor of the free market, libertarians, would tend to say this is all you need. That if we just have this whole string of just contractual agreements, then society will be just. And I don't think that that's enough. It's a beginning. But I think we also need to look at the bigger picture when we ask about the relationship of the whole to the parts, whether the whole is a family or a government or a globe, and then the relationship of the parts to the whole. In other words, what do individual citizens owe back? And of course, you all know one thing, taxes, right? That's the kind of one that always sticks out. But achieving justice, which could be referred to with a capital J, kind of like the reign of God, if you're Christian or Jewish, would be the point at which there is absolute and total justice, what we might call heaven, the reign of God, the kingdom of God. Now, obviously, we are nowhere near that at this point, but this network, this evolving network of just relationships, is a start on it, and we keep working at it. So really, our understanding of justice might look more like this. It isn't just a series of contracts between individuals. It is this interwoven network of relationships which has now become global. Once it was little medieval villages, then it was city-states, then it was nation-states. Now we're into a global sense of justice, and we're inextricably linked to other people around the globe. So these three fundamental things, the common good, human dignity, and justice, I hope you can see all of these are interlinked and they mutually reinforce one another or not. If you've got one of them missing, there's going to be a problem here. And just let me mention two or three other things, and then we'll stop for questions. There are some, I wouldn't say lesser principles, but they're kind of derivative from the key principles that we just talked about, those three. One of them is the virtue, again, of solidarity, which basically means that we believe and act as though we believe that we have more in common with people who are socially, geographically, or economically distant from us than we don't. It's kind of back to the subway, the L train example, that I can look at that train and think, wow, that person is not like me. But solidarity means that I understand at some profound level that, yes, that person is just like me. Different circumstances, but just like me, that we are all in this together. And Christian scriptures and Hebrew scriptures and many other religious traditions teach that in order to live that, we have to give a preference to the poor, who usually are the first ones to be put outside of that togetherness, because they often don't have the means to get into the club, kind of. So we emphasize a preferential option for the poor. But think about this sometime, in terms of solidarity, how hard it is to feel and act as though we are really all in this together. It's tough. It's hard to do, even in our fairly homogeneous society. Another one is subsidiarity, which goes back to this question that we mentioned earlier about socialism versus the common good. Our understanding of the common good is that it empowers people and enables participation. So when we provide, it's pretty hard to participate in society if you're sick, if you have a broken leg, if you're uneducated, if you have no friends. Those things make it very difficult to be active players. So subsidiarity means that we try to enable people at the lowest level possible. And primary care, often that's where that happens. We're trying to keep people in the game, as it were. Stewardship, two more slides here and then we'll stop. Stewardship, or taking care of what we've got and realizing that the things we have, we do not radically own. Now again, if you remember those comments earlier about a right to health care and, well, they don't deserve it because they couldn't pay for it. Well, who does own health care? Health care is not owned by physicians or doctors or enormous health care systems, one of which I used to work for. We hold that in trust and we steward it for the sake of the common good. And the church talks about this as the universal destination of human goods. In other words, the goods of the earth, and these include even things like medical training, or maybe especially, we don't own them. They are the result of learning and suffering and experimentation of millions of people over centuries. We inherit it, and you as healthcare providers, as students, will be entrusted with that information, but you always need to remember to kind of have a light hold on it, that it's given to you for the sake of service to others. And we have a tough time with that in this country because we've got such a consumerist approach to healthcare that it kind of militates against that. Benedict XVI, in his encyclical Caritas and Veritate, says that he refers to it in terms of the logic of gift. He said, we are very adept at speaking the logic of the market, where we buy something and get something back. But he said the logic of gift, at least from the perspective of our religious tradition, is prior to that, because we don't own these things. Yeah, we buy and sell in a sense, but in the end, we've got to remember these things were given to all of us. And the last thing I'm going to say here is that in terms of a right to health care, one of the biggest mistakes I think we made here, if we go back to that slide where I had the 3 parts of a right, the subject, the term, and the object, many Americans, or many people generally, I think the term or the person upon whom the obligation to meet my right falls is the government. That's not the case. The obligation for these basic human goods falls upon society. Now, we may choose one government form over another to facilitate that, but it is not a government giveaway. At least in our view, we see society as ultimately having stewardship for these gifts, and society, through whatever means it chooses, and we've had lots of different political systems, then has to make decisions about responding to these basic rights in terms of meeting the obligations that they impose. So if we can, it's really hard to do it in the current debate, but if we can move away from thinking this is all just a big government giveaway and think about society's obligation to meet basic human rights like healthcare, education, public safety, and so forth, then we get on, I think, more solid and workable ground. Government can be helpful, but it's not where the claim ultimately falls. Okay, I'm going to stop there and see if you have any questions or comments.